The next session is a panel discussion on management of pancreatic neuroendocrine tumors. Panelists will invite Dr. Jayapal R, Dr. Sudeep, Dr. Nitish, Dr. Soumya Sani and Dr. Mukundan. This will be moderated by Dr. Puneet Dhar sir.
So from a malignancy which doesn't show too many outcome changes, we come to a disease which has too many options available and many of them work. And sometimes if you don't do anything also, it might be possible to go ahead. So I've got the vexing issue of pancreatic neuroendocrine tumors. It's rare enough, it's common enough, it's getting commoner, it's getting diagnosed, which are significant, which are not. And I bring you greetings from Faridabad. And to address this dilemma, we have a galaxy of specialties which can deal with it, and what is the actual, there's so many guidelines, so many kind of subtypes in this, functioning, non-functioning, what grade. So to address this Mahapanchayat, we have a radiologist, Nitish, Soumya, nuclear medicine, Mukundan from medical gastro, Jayapal and Sudeep from surgical gastro. So the questions we are trying to address is what is the natural history, what is the best way to diagnose, imaging, biomarkers, can the biopsy predict, is it useful, safe, dual phase imaging in NETs. I think the functional imaging is one of the most important topics. What's the best treatment, is there always surgery, and are there any viable non-operative options or indeed not to do anything. So I think the single most important thing is the WHO classification where the NET grade, and I think this August audience, everybody is familiar with the 3 grades. It's basically the 2023-22 is also is the same as the 2017 essentially, where they basically the only thing which they added was this green bit. They recognize that the G3 is not all neuroendocrine carcinoma alone. It also has a small subset of well-differentiated tumors. So clearly the correlation of tumor grade with survival has been there. So with that background, I think all of you are familiar with the G1, G2, G3, where we either use the mitotic index, but now more and more, most of the guidelines, earlier they used to say they're equivalent, but if you don't have the MIB labeling, you can at least do the mitotic count per high power field, and they're roughly similar values, the 3 to 20 being G2, and less than that is G1 and G3. And clearly it's correlating with the survival. So with that, we come to our first case scenario. 47-year-old male with pain abdomen for 10 months associated with generalized weakness and weight loss. So ultrasound is showing multiple hypoechoic level lesions. So basically with a single lesion, surgery is probably the best, so we're not covering that bit. We're doing all the ones where, since it's a multidisciplinary audience as well, so the ones where there are some either controversies or some clear messages which we need to take home. So this ultrasound is showing multiple hypoechoic level lesions. Patients looking reasonably well, walks into the clinic and the possibility of NET is high. There's a pancreatic body lesion. The biopsy shows a G2, the MEP labeling index is 10%, and has already received sandostatin LAR for 3 months. Has persistent abdominal pain and now is referred in August 2019. What would be the best imaging approach in this case? I think we can start with the radiologist.
So good afternoon. As we know, the pancreatic neuroendocrine neoplasms are highly vascular lesions. So the basic CT protocol include non-contrast followed by arterial phase imaging followed by pancreatic parenchymal phase and venous phase imaging. The arterial phase imaging is usually done 20 seconds post contrast injection followed by pancreatic parenchymal, which is 30 seconds, and venous phase, which is 40 to 60 seconds. So these pancreatic neuroendocrine neoplasms are highly vascular and they are picked up in arterial phase imaging, including the metastatic lesions as well as the primary lesions. If you are seeing a hypervascular lesion in the pancreatic parenchyma, apart from pancreatic neuroendocrine neoplasm, you also need to think of other imaging differentials, which includes hypervascular METs. As you can see in the first image, there is a large exophytic heterogeneously enhancing lesion which is seen in the left kidney. Apart from that, there are few enhancing lesions also noted in the pancreatic parenchyma. So in this case, we also need to think of metastasis from RCC. And the second image shows a focal lesion in the tail of the pancreas as labeled in the arrow, the second and the third image. So it is a case of intrapancreatic accessory spleen. So the clutch point is that the lesion always follows the enhancement characteristics as well as imaging appearance as similar to the spleen, which is shown near to the pancreas. And then the third image is a case of retroperitoneal paraganglioma, which is also a hypervascular lesion, but the origin is not from the pancreas, and we also need to delineate the close fat planes loss between these two organs. So next slide.
So does it have to be always hypervascular only for NET? I mean, when it's hypervascular, of course, we think of NETs and we have to look for these.
So in NET, the lower grade lesions usually are homogeneously and intensely enhancing. As the grade of the lesion increases, it becomes more heterogeneous and shows more area of cystic areas, calcification and hemorrhage within it. So the lesions which are usually lower grade are intensely and homogeneous enhancing. If you are seeing multiple heterogeneous appearance and cystic area, you need to think of higher grade tumors. So
I think we collected from a lot of centers, many of whom are here, cystic tumors, and actually cystic NETs was one of the second commonest. So it's an important message. It need not always be hypervascular. No.
Yeah.
Sorry, go ahead.
So the other differentials include GIST tumor, which is arising from adjacent duodenum, and pancreatic solid serous adenoma and pancreatic hamartoma. Although the incidence are relatively less and the imaging appearance are not very typical like pancreatic neuroendocrine tumor, these list also should be kept under our differentials.
So that's as far as the radiologist is concerned, but there's one place where functional imaging I think is
this is a slide showing the key characteristic imaging differential, how to differentiate between these differential diagnosis and between the NET. So it mainly comes to role in non-functional NET. In functional NET, we do have clinical evidence to support the diagnosis.
Thank you. So, Dr. Soumya, what is the workhorse of the functional imaging?
So coming to the nuclear medicine perspective, in a patient like this, we would want to do something called a somatostatin receptor-based imaging. Knowing that pancreatic NETs express somatostatin 2 more than any other somatostatin receptor. So we target this receptor using our functional imaging. The tracer used is gallium-68 dotatate. And in this patient, we see there is multiple avid liver metastasis and nauseous meds.
So any difference between dotatate, dotatalk, dotanoc? And there's a slight mismatch here with the status and the burden. Any role for FDG PET, what we call the dual tracer imaging?
Yes, so the next slide, I'll just explain the different peptides that are used in this image is dotatate, dotatalk and NOC. The primary difference is basically the affinity. So the highest affinity for somatostatin 2, which is expressed most in NETs, is dotatate, followed by dotatalk. And there is a broader application for NOC imaging as well. It doesn't just target somatostatin 2, but 3 and 5 as well. So in this case, we would recommend a dual imaging as well, which means the same patient would undergo a fluorinating FDG PET-CT, FDG being a fluorodeoxyglucose agent. So here the principle is basically cells which are more poorly differentiated should pick up more FDG uptake. The more they express the receptor, the higher the dotatate uptake. So it's a flip-flop mechanism. We see that even in that functional imaging aspect there, the more well differentiated they are, the more they express the somatostatin receptors, therefore higher the DOTA uptake as compared to the FDG uptake. So the more poorly differentiated they get, the FDG positivity increases.
So in a resource constrained setting like ours, would you recommend, I mean ideally I guess we should do both because we don't know where in the spectrum they might fall. Do you think they would need even in the extremes, the other one also would be needed?
So it is considered in cases where the dotatate uptake is not as high as expected. In that case, then it would be better to do a dual imaging because we know the tumor is heterogeneous. We'd like to see which expression is higher.
So over time, we've actually seen that many of them don't behave with what the biopsy may have shown. So if it looks like it's, and there is frequently been, eventually when 2 years later the surgery was done, there's been a mismatch between the original biopsy of G1 with the G3 or G2 in the. So this can give you a functional. I think if you do a matching of the two, both done at the same time. Would you agree, Samya?
So I think that should be done in borderline cases where the uptake of dotatate is not as high as expected, and also if it is somewhere between grade 2 and grade 3. We know definitely grade 1 and 4 there is a clear-cut decision already, but that borderline cases is when we would like to do a dual imaging.
So for these sort of indications, I think both
Yes.
should be done, isn't it? So I think you just already outlined all this. So benefits being, if you see a very high, if the FDG is not avid at all, then you know it's tumor homogeneous there's no pockets of, so we didn't really cover that, we don't have a pathologist, but one important thing is, you'll see sometimes in your report a value, it should be a single value given, that's every guidelines actually mentions that. I found a lot of pathology reports where they'll say, 1 to 3%, the Chi-67 or the mitotic figures are 1 to 3 per 10 high power fields. That is unacceptable. You have to talk to your pathologist. They have to look at the hotspots. So their worry is that there are some areas which are showing a lot of activity and some areas which are not. So they have to look for the hotspots, and that's the one which determines. So whichever is the worst is the grade. So they look at the hotspots and then count there specifically. So you need to discuss this with your pathologist sometimes, now of course they're all on board, but I did see a lot of reports with that. So, definitely, as she said, in disease progression, you might need to change therapy, and for prognostication, especially in the intermediate grade, and it's one step, as we've all been saying, talking, the mantra here seems to be personalized medicine. So there's some, would you like to talk about the net PET score?
Yes, so in dual imaging, when a patient undergoes both FDG and dotatate imaging, there's a net PET score that we give. We know that P1 and P5 is the extreme. So higher the SSTR positivity, it is P1 and P2. 3 is where the expression is similar, but 4 and 5 where FDG expression is higher than the SSTR. So this is a prognostic score. Up to P2 we know that PRRT or peptide radionuclide receptor therapy is preferred, but higher the score, the PETNet score of P4 and 5, chemotherapy would be more beneficial rather than a targeted receptor-based nuclide therapy. So this is a prognostic score that we give in dual cases.
So this is another reason why, in the more advanced grades, you might need to do both the tracers. So if there's only one message you take from here, apart from the grade, would be the importance of the dual tracer. So this is...
This patient, we find that the dotatate expression is much higher than the FDG. There's hardly any uptake seen in the first set of images, which is the FDD scan, but the patient has highly avid dotatate lesions.
But if it was reversed, what would be a worry?
So a chemotherapy-based treatment would be preferred in this.
The important thing is whenever we get two tumors or a collision tumor, whatever, a prostate tumor with a pancreatic tumor, it's the most aggressive one which is going to determine prognosis. So we have to treat for that. So absolutely spot on. What about biomarkers? Anybody wants to take that?
Biomarkers in pancreatic neuroendocrine tumors or neuroendocrine tumors as of now have a role only in monitoring response, assessing the tumor burden, and see if there is a recurrence of disease after a specific treatment.
What about diagnosis? Is like if you want to, you found a hypervascular lesion and you don't know whether the patient can afford it, so can it help you triage which ones to?
Biomarkers currently available, namely the most commonly used is chromogranin A. It is not very specific in the sense it can be elevated in multiple other conditions. Even in other non-neuroendocrine tumors it can be elevated. In benign inflammatory conditions also it can be elevated. So at this point of time...
Guinness record holding drug, proton pump inhibitors, I think it will help. So you need to stop it for at least a week.
Other tumors. So this new marker, which is the pipeline, that is NET test, which is, I have not used it, but it's supposed to be very promising. This is actually liquid biopsy, which is, you take it from the peripheral blood and you look for gene transcripts of neuroendocrine tumors. And this is found to be very good when it comes as a diagnostic marker, as well as for both prognostication and looking for relapse. So when you have a net test, the cutoff usually given in literature is 40. If you have a cutoff less than 40, it means that you're dealing with a cutoff less than 40, you're dealing with a stable disease or a patient with a low tumor burden. But if the cutoff is more than 40, we're looking at an aggressive tumor and likelihood that this patient might be having a overprognosis. Same thing applies after you have done a surgery or a treatment, and then you reassess the net test score. If it is less than 40, that means the tumor is in stable state or there is good response to therapy. But if it is showing a progressively increasing value, then we are dealing with recurrence of the tumor or inadequate response.
Yeah, it's unfortunately not available, but I'm hoping others, there's a lot of scientists here, so either we develop a similar multi-gene assay or for our own population, or we get the net test here. But both Jay Oberg and Urban Modeling, who have been experts in this field, have actually validated the role of this, and these are the sample reports which looks like that. So definitely a good biopsy, immunohistochemistry and expert process is extremely good. Any thoughts on, because when you do the EUS, you take only FNA, you want to say about biopsy versus just cytology?
First, it depends on what we see in the imaging. If you already have a metastasis in the liver, then I think that should be the first area of target because it's easy to take and it's much easier for the patient also. But if you have an isolated tumor in the pancreas, then EUS guided biopsy is suggested and first line. And nowadays, with the newer needles, of late we use only core tissue needles. We don't do FNAC anymore unless it's really necessary. So the newer FNB needles, preferably the 22G FNB needles, we get good core tissue, and if we have a good macroscopic and rapid onset pathologist, and if we can have a adequacy of the tissue, then I think FNB needles, the tissue we get, we have a specificity or diagnostic accuracy ranging up to 90 to 95%. Quoted in many of the Japanese studies and one or two languages.
So, in your message, the score is better. Would the surgeons agree that it's very quiet in the field? The field really belongs to you to operate. Any other difference of opinion, or do you see anything else? No? Okay. So we go on to the second case. 37-year-old male with mild hypertensive MR abdominal pain. Ultrasound shows this tumor. It's a non-functioning PNET, 2 big liver paralytic nets, all are DOTA avid FDG negative. So probably a lower, but the liver biopsy shows a G2 net, Ki67 is 5%. The tumor board decides to give neoadjuvant PRRT. So this was, we hardly ever use neoadjuvant treatment. Are you guys, the surgeons, comfortable with giving? Do you think any need for any neoadjuvant therapy? And here you have a primary along with METs. Because of urothelium, we know that.
In this case, showed actually a good grade 2 with 5%, and there are DOTA avid so and the PRRT going to be.
So if the liver mets were not there, you would have probably gone ahead with surgery, isn't it? First.
Yeah.
Okay.
And he looks like a 37-year-old, and we can assess for a response scan and plan for a definitive R0 resection. It's a only limited liver disease with a 2 big only, but we have to properly evaluate the patient of the FLR, how is the liver function after the PRRT, and so definitely metabolic functional scan needed before planning any definitive surgery for this patient. We would like to add something.
So I think we've already, the FDG, you want to talk about the.
Yeah, so the images of this patient, we find that the DOTA avidity was much higher than the FDG in the liver lesions as well.
Yeah. So you added this cartoon.
Yeah, this is just to say that the whole concept of theranostics, where the same target and the radiopharmaceutical is used. The first one, if you look at the image, it's gallium-68, where we use it for imaging. But targeting the same receptors, we use a beta emitter or an alpha emitter for the therapeutic application.
So it's the advantage of getting to know, identifying receptors that we can actually target that with, and with much less toxicity elsewhere. So could you tell us about the therapy itself? What molecule, why?
Yeah, so gallium dotatate, when the patient shows avid lesions, they are amenable for a lutetium or an yttrium, which are beta emitters. That is tacked to the same dotatate and injected IV in the patient. So it specifically targets those tumor cells, and by the beta radiation of lutetium or yttrium, the tumor cells are killed. So in this case, we see after 2 cycles, there is significant response in terms of the avidity of the lesions. It has come down in this patient.
Any choice between lutetium and yttrium? Earlier we used to have yttrium. Is it safer now? Or?
It's more or less same in the efficacy, but lutetium is more easily available than yttrium.
Okay, that's what the nephrotoxicity is also a bit less with lutetium.
Yes, the nephrotoxicity.
That used to be the worry for surgeons that by the time they come for surgery, we might have a bit of an issue.
Just a word on alpha therapy, which is an emerging option now, especially in cases where everything has been tried. There are few case reports that giving alpha therapy instead of beta therapeutic agent like lutetium or yttrium still is efficacious because it is more potent. There's an image showing that. This patient in spite of lutetium did not show much response, but following the alpha therapy, the last green arrow, we find that there was significant regression of the disease. So it's an emerging option.
So this is, I think we need to know about this as well, because if we don't know, we're going to not send the patients. Nuclear medicine guys tend to be very quiet in the background. So this is one area where they need to be absolutely extroverted. So this definitely, when we organized the neuroendocrine Asia Pacific meeting about 8 years back in Cochin, I remember the guy who delivered the talk on neoadjuvant therapy. His first slide was, you got to be joking, and the second slide was there's no evidence. But just in these 7 years, so much has come up in terms of PRRT as well as other therapies. So definitely is the meta-analysis of so many studies which showed that even though we're not there yet, but there is some role in selecting patients and could reduce the tumor size, age, and in some cases even give a chance of radical resection. Still, we don't know what is the best, but I think so long as we're able to do trials with groups like these, I think they're going to get. Now coming to what really excited the interest of neuroendocrine was the functional tumors. So initially, what we saw were mostly the functional tumors. Now we realize there's so many which are. Any thoughts on why the non-function happens when they're actually neuroendocrine? Any? So one reason we used to say for carcinoids was that all the neurotransmitters get digested by the liver, so it doesn't reach. There's a lot of intratumoral metabolism also possible within the cells itself. And finally, the hormone elaborated may be actually inactive, something like pancreatic polypeptide or the somatostatin itself, So I don't know whether it kills itself or not, somatostatin or not. But anyway, this is another of the functioning tumors. One of the most vexing problems is of the Whipple triad. Sometimes if it doesn't come with the triad, if it comes with only the neuroglycopenic symptoms, I've had patients who were delayed for even 10, 15 years, labeled as psychiatric and all that. So fortunately, most casualties now have sort of protocol of doing the blood sugar, so they do tend to be picked up. So this is one of those patients who was 45-year-old insected with an 8-month history of episodic confusion, diaphoresis, palpitations. The episodes occurred mostly during fasting states, particularly early morning. And there's a recent episode of loss of consciousness during a business meeting, so they insisted that you have your executive health checkup. The family reports personality changes, difficulty concentrating. Some of them actually become little obese also because of tendency to eat more. There's no significant medical history, non-diabetic. So one episode of fitness, hypoglycemia was there, glucose 35 milligram was there, and the symptoms resolved with glucose administration. And insulin levels are inappropriately high, and the C-peptide was also elevated. So C-peptide is done to make sure that this is not a factitious, it's an endogenous, the proinsulin is also elevated. So how do we localize? So we saw how we can localize if it's seen on the imaging and all that, we saw those, but many of them do not get localized. How would you, any of you like to?
With these symptoms, the first line of investigation will be a cross-sectional imaging, and if you don't see any lesion in the cross-sectional imaging, then you subject them to endoscopic ultrasound guided scans. The possibility of finding a smaller lesions will be a little bit higher. Say if the patient fits the criteria of insulinoma by means of biochemical test, like satisfying the Whipple triad, then examine scan also plays a role, because in insulinomas, they will not be in Dotamox scans or Dotamox scans, the uptake will not be there, particularly for insulinomas, because they don't express SSCR2 Whereas they will be specifically on receptors, but eccentric scan is the most specific one for this.
So it's a similar thing to Dotopodet. It's called the GLP center-based ligand.
So if the lesion shows up in either endoscopic ultrasound and we confirm it with an eccentric scan, then the treatment option will be to operate and remove the functional tumor. So if even in those scans, if it's not showing up, then and if the biochemical test fits the criteria of insulinoma, the next option will be to previously there used to be an arterial stimulation venous sampling, but it's considered invasive and it's very operator dependent. So nowadays it's not very routinely done. The next step will be to explore and do an intraoperative ultrasound. Intraoperative ultrasound.
So one important message that the older textbooks usually show this venous sampling and arterial stimulation. These are now done only after failed exploration. So exploration, the combination of exploration and an expert intraoperative ultrasound picks up virtually almost up to 98-99% of lesions according to various studies.
So I'd like to add one more thing. The close umbilical insulinoma will be entity called medulloblastosis, which is mostly seen nowadays after bariatric surgeries. The only difference, because both these conditions will have very similar expression of biochemical test, and the scans will not be showing any lesions. Only difference will be they will during intraoperative ultrasound you will be able to pick up insulinomas, whereas in medulloblastosis there will not be any mass lesions per se. So once we confirm the lesion with the intraoperative ultrasound, we can again do a venous sampling intraoperatively to establish the diagnosis further, and then we can identify us based on the condition.
Yeah, so older textbooks used to suggest that you could do a blind distal resection. That's no longer recommended because it could be anywhere. If you actually close the patient and do either do the venous sampling, it suggests then you can go ahead and do
to answer this post-bariatric scenario. Usually in post-bariatric scenarios, we have a post-prandial hypoglycemia and not a fasting hypoglycemia. And it's because of islet cell hyperplasia. So,
another scan can show the diffuse
the clinical scenario will be more of a post-prandial hypoglycemia, and we use a mixed meal test instead of a fasting test to make a diagnosis.
So apart from bariatric, I think you have primary also. We had one infant actually where we ended up with a near total pancreatectomy actually. So what about enucleation versus required enucleation versus resection?
Once imaging suggestive of a proper clinical findings are showing that there is case of insulinoma and the small size lesion which can be actually not so much related to the MPD. We can enucleate like an antigen process, or it's only a tail mass where you can get away without doing the major pancreatitis.
So far away from the
yeah. So intraoperative also in that way can help to localize and what is the relationship with the MPD. And sometimes the eccentric scan can pick up those nodes which cannot be seen in the Mary or MRCTs. Those nodes also has to be targeted in those like insulinoma cases. So definitely sampling with enucleation or a dissection for according to the localization of the tumor.
You also, after you finish the thing, you can also do, I think there's an immunoreactive insulin, again it's not available, so there's a rapid fall in that apart from, you can stop giving glucose supplements, you drop the anesthetist who's scared of, that you might activate it. This is the only one which is benign. All the others actually, apart from insulinoma, most of the others tend to have a more malignant potential, so you probably do more formal resection in all the functional tumors apart from insulinoma. So I think one important is there can be multiple lesions as well. So it's important to have the intraoperative. We are trying from the associations to actually have a lot of training for the surgeons for intraoperative. In addition to getting the experts into the field, because sometimes the logistic issues they refuse to come with us.
The role of intraoperative it helps us to localize the smaller lesions and also its relationship with the pancreatic as well as with the vascular structure. And also it can pick up multifocal lesions which are usually associated with syndromes like benign and VHL syndrome. The other important thing is that we need to differentiate the tumor from the other benign lesions which can occur in pancreas, like some small pancreatic cyst. We should not mistake that for the lesion. So we need to prior correlate with the CT images. If the lesion is enhancing, it might be picked up in CT. Sometimes the lesion can show cystic changes, will better appreciated in MRT to better images. So the small lesions are better seen. And the one more advantage is that due to its proximity with the lesions, this ultrasound can show better cystic changes, microcystic changes, which are missed in the conventional cross-sectional image.
So there can be multiple also, and you might actually see one lesion on a pre-op scan. So if you palpate and you find it somewhere else, you can actually confirm by intraocular ultrasound, and of course send that for nuclear death, send that for frozen section.
And it also helps us to localize the oligo-liver metastasis.
Absolutely. And you can actually add that at the same time, yes. Absolutely.
So this is just an example of, so next, the example of excellent scan which was done in our center. Like sir already mentioned, insulin's SSTR expression is very low. So what we target is the GLP-1 receptor. And excellent is basically an analog of the GLP. So here we see a 50-year-old lady who had come with recurrent symptoms of hypoglycemia. And her C was actually reported as normal, but the excellent eventually picked up this focus of uptake in the renal pancreas, which was removed and had come as a biopsy. Just to highlight the role of functional imaging in this case.
Rishikesh, we had one, a person with deciduoblastosis, and we could actually decide which, because we didn't want to do it, we didn't consent for a total, so we could decide to do, see which side the extended is more, so we have sent to PGI to the extended, so yeah, very useful look there. So then we come to, sometimes we have these, so this is one of those reverse cases where this is actually, taught me not to judge on the phone. So I got a phone call from a gastro head saying there was a 73-year-old guy with upper GI bleed, and when they did a endoscopy, they found a lesion. So this is technically not pancreatic, but just to show you the difference in the imaging. So we thought we will have to end up with a pimple. Patient was on full hemodialysis on day. So on the phone I said, G3 is like pancreatic cancer, it's going to have a very bad outcome. Try to talk about it and shut the phone. It was a protocol, we did a neural trace imaging, and then it was presented to an MDT. So how important it is to have all the objective things. A big lesson to me. And this patient actually showed only FT and no meds. So the medical oncologist called back to say that you had sort of suggested that patient not go ahead with this, but this means they can't take any of the somatostatin receptor based therapy. So won't be able to use LAR, won't be able to use anything because it's not avid at all. So do you really feel that this patient will have long-term chemotherapy, and with a high Chi-6 like this is only a platinum-based chemotherapy, so a very toxic thing for the rest of his life. He's going to be, look at the guy, he was one hefty guy, so never judge. Look at the full picture before you take a call. So the tumor board suggested we go ahead to the section, and actually when the medical was very at D2, it was a T1 going into the with the maximum mass, and we were able to get away with an extended gastrectomy. So this was just to show you about the when it's the reverse, when it's FDG avid and rota is negative, there's no point in all those. So we might need chemo. So coming to the unresectable metastasis, you want to talk about what are the options available?
With unresectable metastasis, we have to look at the layer of differentiation and layer of tumor, and then after and whether the lesion is anti-gravid or SSTR. So based on these things, we will subject the patient to say if it's SSTR, we will put him on upfront somatostatin analog or a PRRT therapy. And based on the response, we have to keep following these patients with the well-fixed because during the course of treatment, initially the tumor which is SSTR can de-differentiate and then can become anti-gravid.
What about the role of the primary cell? Like in mid-cut carcinomas, we have evidence that role of the primary. What about pancreatic?
In functioning tumors with unresectable means, there's a definite role of resecting the primary to improve the quality of life. There are some papers which show that even in non-functioning tumors, resecting the primary will help to reduce the tumor burden, and then the response of this metastasis to the conventional chemotherapy regimens will be better.
So So even though you don't improve survival, you might actually get a better progression free. Definitely a symptom improvement in the functional and sometimes even the non-functional, as I said. So systematic review showing somewhat similar, slightly varying, but quite a few of them actually show that even though overall survival might be a tad better, even though it didn't reach statistical significance. So one of the other options that become sort of closer to the liver limited disease after sexual decline, what are the options for the liver itself?
So, immunological biological therapies in the form of liver-directed is an option. The ARR is the liver-directed therapies like PACE and TAR, and gland embolization is also effective in some cases, but they are not suitable for ACE or TAR. In a very limited set of patients where it's a well-differentiated grade 1 tumor without any extrahepatic disease, and if the primary is taken care of, then liver transplant surgery can be used. Say if delivery should be considered only if you could remove more than 70% of tumor burden, and if it's technically doable.
So earlier we used to say 90%, but now I think many studies are actually showing if you can get just 70% out, you might get a significant progression-free survival as well. Transplant, as Steve Jobs showed us, has a much more limited role, and it should be done very highly selected, make sure there's no extrahepatic disease. Do you agree? So.
Transplant options are there, but currently in Indian center, definitely AET, only those AET center, disease has to survive, patient also has to survive 6-month duration, and the rate of the tumor has to be low.
So we are actually similar Milan criteria which shows stability and non-progression and no extrahepatic disease coming up during that time. The longer the duration, the better. And the whole lot it has to be low grade only, not high grade. High grade is exactly like exocrine tumors. So what about the other therapies available to be?
Similarly, what Dr. Jaipal said about the ARTs, the different therapies are there, and apart from that, biologicals like urologists, imaging is there in a way to show us much more long-term benefit. So
long as the understanding receptor activity is there, the first line is so we have very useful initially. It was used only for the functional tumors, but I think the anti-proliferative effect proof of concept came up, and now it's being routinely used. You can use monthly the long-acting analog, and only when you see growing, then switch to everolimus and sunitinib or even PRRT. But if the structural receptor non-avid ones or the ability is more than the more lesions which are FDG avid and not showing, there is no point in giving any of these treatments. It will reduce those shadows, but the patient is going to exactly progress on the most. Then you need to give chemotherapy. Any thoughts on what kind of chemotherapy we give?
So in those cases like SRI negative, high grade, differentiated, captive disease, or some platinum-based chemotherapy has to be treated like a pancreatic carcinoma where they have been delivering. According to the performance status, functionality, so you have to assess the patient, and that's most of the chemotherapy line you have to think rather than going to upfront resection for this locally advanced with a high grade as well as a SRI negative. So definitely surgeons are not much hopeful in the situation, but definitely chemotherapy can add some benefit in that scenario.
Since it's slow, you can get quite a substantial good quality of life with the therapies, and we start with the least toxic and go to the most toxic. One word I'd like to request all of you is we have a very cheap drug available in India called streptozotocin. Since the big pharma doesn't want to, it's cheap and has a good effect. We are slowly seeing like penicillin B and all getting out of the market first. We have no oral penicillins left now. So I think we have to make sure that we use them whenever it comes, and the industry actually promotes it. But I know one important thing he said, the important thing is that the Ki-67 is less than 55, and then the K10 is very useful. Again, I think we are seeing a lot of personalization of medicine here. We can do some studies, and I think many of them are coming up with the AI radiation or things, so upbeat about it. I think we're going to see much more of that. So there is a 6 NGMP, 6 methyl-guanine transferase. If that, showing receptor expression, then we can use temozolomide. So we can actually decide which kind of treatment to give. And I suspect we will see a change to G4 as when the Reproduction Human Societies change it to. So what about many people actually wonder, do we get so slow growing? Do we need to actually do anything? So, any thoughts?
In any functioning tumors, better if the performance status is good, better to resect the lesions. The surprise to particularly non-functioning tumors, the lesion is small in size, less than 2 centimeters, G1 stable disease, and if it is non-functioning, then these patients can be kept on a close waiting watch for whatever. We can review them every 6 months.
So this is an important message. This is one of the very few tumors like prostate where you can actually see the what way the growth can be seen, because many of these elderly lady comes to you with a small net in the head of pancreas. The only risk she has as a surgeon actually, operates her, she might die, she might live for 10 years. I've got many patients who've been following me for 25 years actually with this disease. Surveillance, we have just briefly.
Coming to non-surgical options, mainly considered only for small pancreatic tumors less than 2 centimeters. Only considered in patients who are elderly, frail, and not fit for surgery, or if patients refuse surgery. So, the two common modalities which have been considered are EOS-guided ethanol ablation and EOS-guided radial frequency ablation. Nowadays, EOS-guided RFA ablation is considered a better option, where you use a 19-watt RFA probe through the EOS scope, target the lesion, and you use thermal coagulation to cause coagulated necrosis. And
so that's an option. It's not a standard of care yet, but I think
clinical success and clinical success have been close to 95%. And long-term studies are not available, but studies of 2 months post-procedure have shown radiological response of up to 90%. And they are associated with minimal adverse, but they are specifically for patients who are not willing or elderly patients not fit for surgery. Otherwise, surgery becomes a mistake.
I think those are the factors that are in mind. You have all those performance status, patient wishes, location. You have higher sort of takes of threshold for surgery if it's a head lesion, the size of the tumor, the growth rate, extent. The second most important is the rate of tumor and somatic expression and the presence of symptoms. So very, very important for all of us to sit together. I thank you for the patience and any questions which are
your case to be referred to this Slovenia. Why couldn't you operate? That's a relation with the relation with
and with liver mets. The whole idea was to see how the patient actually progresses. That was a more decision because the PRRT trials have come by then, showing that there is a benefit, and if you are able to show that there is an improvement, you might actually be able to reduce the number of the volume of liver dissection as well. You might be able to limit it because you might need multiple levels. So one now, one 5 years later, one 10 years later. If you remove substantial amounts and then you have cash and all that, I think you might overall limit. This feeling that only the surgical machine was going to push that through, we're not there for neuroendocrine disease.
Because the studies are saying actually you should dissect it for you.
Yeah, for the non-metastatic, no doubt about it.
Metastatic is what is talking about you.
Yeah, so even for metastatic, you're right. If you can remove the entire thing, it is. But here we know that there was a thyroid, we put it exactly for that reason. The thyroid is also there. So there might be other issues which manifest. So some systemic therapy is important to supplement that. And if you do it before surgery, you get the luxury of watching how it's going to improve. And then you can limit the total volume of liver dissection as well. Especially the fact that they are definitely going to come back with recurrence, again and again.
Because in the trial saying we were taking 4 doses of that would finish off most of our.
Sorry?
That is 4 cycle of radionuclide therapy.
Not necessarily. Not sure that.
That is a European trial which taught us the single advantage of radioadjuvant.
No, I think Sonia, would you like to elaborate what would be your
Complete residue is at least 4 doses. You can go up to 6.
Okay. So at least you get to see the biological therapy. I mean, many of these patients actually, if you follow them up also, the actual rate of growth may not be very high, especially if it's G1 and all that. Anybody else? But you're absolutely right. We don't know it's discussions like these which we, like I told you, people refused. When I talked to a lot of Tata and AIMS, for some patients they refused, and now the same guys are actually so aggressive about it. Sujay would, the PGI guys, the PGI guys showed so many studies which they've done on neoadjuvant as well, with very good salutary results. Any last minute thoughts, or Sujay?
I'd like to caution that if there is a situation where you can get away with a liver resection for a metastatic disease in the liver, it's
Single lesion, agreed, absolutely agreed.
single or a large lesion which is compatible with a hemihepatectomy.
Absolutely.
It should be done straight away rather than subjecting the patient to PPRT and then see, because I've had situations where the patient has developed actually a bone marrow kind of a failure kind of a situation because of long-standing PPRT, where the hemoglobin and the platelet levels would never rise. And at that point of time, when I had to do a liver resection, it was a very bad situation.
Right. So I mean, I guess we have to see both sides of the which would be the safest for the patient. Absolutely, personalize it. Any more questions, or we can? I think we're done for time. Thank you. Thanks a lot to my panelists.